in San Diego at the 2016 American Society of Hematology Conference, and joining me is David Andorski, Dr. David, I should say, from the Rocky Mountain Cancer Center. David, it's good to see you.
Nice to see you.
So you're a very busy guy. You're treating patients and you're doing some research, and I know you presented some things here at ASH. Very important, a lot on the horizon in terms of cancer care. What did you present at this year's ASH conference?
So this year's conference I presented early results from a clinical trial called the MAGNIFY trial. This is a research study in patients with indolent lymphoma. So indolent non-Hodgkin's lymphoma comprises, there's probably several tens of thousands of diagnoses every year in the United States. These are chronic diseases. The average survival for patients is around 10 to 15 years, but they're not curable. And so we're always working to optimize our therapies, help patients live longer, but also live better with fewer treatment-related side effects and complications, just because it's more of a chronic illness than something you treat intensively up front and then you're done. So this particular study looked at a newer combination of medications called lenalidomide, or the brand name is Revlimid. Lenalidomide is Revlimid, combined with an immunotherapy called rituximab, which has been around for a while. So together we call that regimen R squared. And this has been looked at in previous studies as well. The nice thing about this treatment for patients is that it's chemotherapy free. Rituxan is an antibody therapy that's been around for probably 15 years at this point. Revlimid is a therapy that's used very widely in multiple myeloma, which is a different hematological disorder, and now we're studying it very intensively in lymphoma. But the side effect profile for that combination is much better than for chemotherapy. And in this patient population, these were patients that had had one or more prior treatments for the lymphoma. Some patients had had 5 or more. And all the patients in the study received this combination treatment for a year. And then one of the scientific questions the study is asking is if we continue one of those medications, the Rituxan alone, which is sort of standard, versus the Rituxan and the Revlimid as what we call a maintenance therapy, so a lesser intensive therapy designed to keep patients in remission or keep their disease controlled at least, where the difference is going to be. So this was an early look at that data, only about 8 months of follow-up on average, but we saw that about 60 to 65% of patients had objective shrinkage of the tumor by more than 50%,
wow,
which is generally correlated with very good outcomes. I can say for myself, my own personal patients in this practice, by and large, it's been very well tolerated. People have had very, very few complaints about it. So it's the kind of thing you can keep going even for years potentially, with maintaining a good quality of life and not really interfering with one's ability to get up in the morning and kind of do what you need to do.
Yeah. You hit on a couple points I want to kind of focus on a little bit. A lot of our community, you know what chemotherapy is, but you hit on this word immunotherapy, which seems to be surfacing more and more. Can you explain to us exactly what is immunotherapy?
Absolutely. So immunotherapy is probably the most promising area in oncology research, not just in hematological malignancies that we're here at ASH to discuss, but also many, many types of cancer. And it encompasses a variety of different approaches. The common theme is that we're trying to somehow harness the body's immune system to attack the cancer and control it. We know from laboratory research that part of the reasons cancers develop in general is because the immune system has somehow failed to recognize them. So getting the immune system to be able to lock back onto that cancer and fight it, as opposed to just having toxic drugs that kill the cancer cells, seems like a more promising approach. So both of these drugs, the Revlimid and Rituxan, work in different ways. The Rituxan is an antibody against a marker called CD20. So normally antibodies are made in your body to fight off infections. Rituxan is an antibody that's made in a laboratory that's directed specifically against a marker on the cell surface called CD20. And the idea is that the antibody goes to the body, it binds to the CD20 marker on the lymphoma cell, and then through a variety of mechanisms kills that cancer cell. Part of the effect is direct. By binding that, it causes the cancer cell to die. But probably even more important is the attraction of other immune cells, T cells and what are called natural killer cells, to that cell to destroy it. The Revlimid works in a somewhat different way. It probably has also several mechanisms of action, but one of the main things that it does is that it augments the response of those T cells and NK cells to the tumor. So we think that there's a lot of synergy between these two treatments. Both of them work modestly well as single agents by themselves, but when you combine them, you're sort of using the Rituxan to flag the lymphoma cell, and then you've stimulated the immune system with the Revlimid, and the combination together seems to be a lot more effective than one or the other alone.